certainly the functions of the parasympathetic and sympathetic nervous systems, but also from a neuroanatomical perspective, how they're different and how they're different from or the same with the somatic nervous system. Remember, with the somatic nervous system, we're controlling our skeletal muscles. We're basically monitoring our external environment versus the visceral nervous system. We're going to have both afferent and efferent, so sensory information from the internal environment, and then also motor information that's going to go to our smooth muscles, to our glands, to secrete, to dilate, to constrict. A lot of other names for the autonomic nervous system. Visceral is one that I prefer. Involuntary, it's part of the peripheral nervous system. So these have Schwann cells on them. These nerves have Schwann cells on them. Our big function is to control homeostasis. And so for most of our organs, we're going to have dual opposing actions where the parasympathetic does one thing to the organ and the sympathetic does the opposite. So typically when you think about the sympathetic nervous system, what do you think of? What? Fight? Fight and flight. And parasympathetic? Rest and digest. Okay, so if, let's take the bronchial tree. What would you want when you're fighting and fighting? Would you want it to dilate or would you want it to constrict? Dilate, because we want a lot of oxygen, okay? And the parasympathetic, we're going to constrict. So when you get really, really nervous, which system gets activated? Sympathetic. So if you have a lot of issues with cardiac issues or stage fright or whatever, you might be on a beta blocker to calm you down. What might be a problem with that? If it's in the bronchial tree. It causes constriction. So this might be a problem for what type of person? Person who doesn't want constriction of the bronchial tree. Any asthmatics in here? Yes? So just thinking about, yeah, you know, sometimes it is just straightforward one or the other, but it's not like we don't want too much constriction of the bronchial tree. So a lot of times you can figure it out. Sometimes they're very coordinated and they're timed. Our efferent pathway, again, is going to be, we're going to have parasympathetic and sympathetic. So we'll start with the sensory part. Our receptors are very similar to the somatic sensory receptors. So we have mechanoreceptors that detect stretch. We have chemoreceptors that are going to detect oxygen levels, pH levels, carbon dioxide. We have pain receptors, temperature receptors. Their cell bodies are going to be in dorsal root ganglia and cranial nerve ganglia, just like the somatic nervous system. So a lot of the sensory information is going to travel really with the somatic information, and that's going to be really the basis for referred pain. We're also going to have reflex activity in the visceral nervous system. So we're going to have synapses with motor or efferent axons to have bronchial constriction or bladder relaxation or contraction, depending. We're also going to have secondary afferents going up the various tracts. So we're going to have information going up with the dorsal columns, going up with the anterolateral or spinothalamic tracts, again, leading to some of this referred pain. A lot of our autonomic afferents are going to be in our parasympathetic system. So we're going to go through our cranial nerve ganglia. So our parasympathetics are our craniosacral region, so cranial nerve ganglia and then the sacral spinal cord. And so in the cranial nerves, our autonomic afferents, our biggies, are going to be 7, 9, and 10. So the tongue and soft palate are our facial nerve and our glossopharyngeal, and then everything else pretty much is vagus. So they're going to, again, transmit that information up to the brainstem. Most of this information is going to merge in the medulla at the solitary nucleus. So our solitary nucleus and our medulla really is where most of that autonomic afferent information is going to synapse. And then from there, it can go to control centers. It can go to our limbic system. If you look at this, we've got our Information, again, our somatic and our visceral information really coming in together. So we've got that ascending information going to the visceral control centers, going to the medulla, but we also have parallel information going to somatic sensory information areas. So that's how come we might have different referred pains where you can feel, you don't actually feel your appendix, but you feel the referred pain from it. We talked about heart attacks and the referred pain to the jaw or the shoulder, again, based on where it's coming in at that level of the spinal cord. There's just our referred pain map. And here's another picture just showing, again, how you can have somatic information coming in along with that visceral information coming in along with the somatosensory, and again traveling in the same pathways, also having reflex loops. So you can have not just a glandular secretion or a smooth muscle contraction, but you'll also have somatic muscle contractions. So you'll have cramping and so forth, somatic motor responses to visceral stimuli. So they travel in the same general pathways. Motor-wise, with our somatic motor system, we pretty much had an upper motor neuron go to a lower motor neuron. The visceral motor system, we're going to use ganglia. So we're basically going to have another synapse in there. So what we basically have is a preganglionic cell body in the central nervous system, and then it's going to have its axon. It's going to synapse with a postganglionic cell body somewhere, and then it'll have its axon that goes to the organ or the muscle that it's going to act on. So it's a two neuron system. So that preganglionic cell body certainly might be in a cranial nerve or cranial nerve nucleus. It could also be in that intermediolateral horn for the sympathetic nervous system. So that's where the preganglionic cell body is. That axon, which is myelinated, leaves, and then it's going to synapse with its postganglionic neuron, which is in some ganglion outside of the nervous system. And then its axon is going to be unmyelinated, and it'll go to the actual organ. One big thing is that we're going to see, particularly in the sympathetic nervous system, we're going to see a lot of divergence. So we're going to see a lot of parallel processing. We'll also see some convergence. Basically, we're going to have a widespread sympathetic response, and that's going to really happen at the level of those postganglionic synapses. Look at that. So just comparing, somatic motor is going to innervate our skeletal muscle versus everything else for the autonomic system. Voluntary versus involuntary. That doesn't necessarily mean unconscious or subconscious. We can gain some conscious control of some of these smooth muscles and glands, with practice, obviously. Lower motor neuron cell bodies are within the central nervous system, so they're either in the cranial nerve nuclei or they're in the ventral horn of the spinal cord. For the autonomic system, they're going to be in those ganglia. They're going to be in the postganglionic. They're the postganglionic neurons. They're going to be in those peripheral ganglia. So it's a disynaptic pathway, preganglionic and postganglionic versus the monosynaptic pathway. Now both do have upper motor neurons that can control them. So here's our somatic motor, pretty straightforward. Upper motor neuron controls the lower motor neuron, which goes to the muscle. The autonomic nervous system, we're going to have our preganglionic neuron, maybe for the sympathetic nervous system in the intermediolateral horn. For the parasympathetic, it might be in Edinger-Westphal nucleus, it might be in a facial nucleus, wherever we're at. Then we're going to have our postganglionic neuron and out, but we also can have an upper motor neuron cortical control of that. So people do gain control of their blood pressure, they do gain control of their respiratory function and so forth, obviously with training. So we talked a little bit about our rest and digest versus our fight or flight. So most of them are going to have dual opposing actions, where the sympathetic will do one thing and the parasympathetic will do the other. Sometimes that's not going to happen. Sometimes they're going to work more in conjunction, or they're going to have different actions on that same organ. There's certainly, both of them are going to have some type of basal level of outflow, just like all neurons. So there's always some innervation of the bronchial tree, of the good thing of the heart muscle, and so forth. So there's some basal level of tone, per se, in the nervous system. So as far as the sympathetic nervous system, we are preparing for fight or flight. So we're going to be trying to increase energy mobilization. We're going to inhibit digestion. So what do you think about sympathetic innervation of the bladder? What should happen? We want to store it? Okay, what happens when people get really, really scared? Yeah, so what's that all about?
It empties it because it's trying to make you lighter.
It's trying to make you lighter.
I don't know.
That's a good reason. This is not the time to go to the bathroom, is it?
No.
But we do, right?
You're not paying attention.
And you're not paying attention. My point is it is. Sympathetic innervation should be sphincter closure and bladder relaxation, so that we don't, obviously bladder contraction and sphincter opening would allow you to urinate. But initial sympathetic response is the exact opposite. My point is, it's not, we have this function, but when you think about it, before you run from the lion, it's probably a good idea to just get that urine out of you and run. Okay, and just go. It's not all that good. And I don't know how that works. It's definitely on my list of questions for God when I get up there. But it makes sense. And then the parasympathetic, again, we're going to try to conserve our energy. We're going to try to rest. We're going to try to digest. And this is when we're going to have urination and defecation. As far as the anatomy of it, we've got our cranial division and our sacral division for our parasympathetics, and then our thoracolumbar division for our sympathetics. So I think let's skip. We're going to skip to get to a couple sympathetic issues, or visceral motor issues. We're going to skip ahead to bladder function. Actually, let's skip ahead to sexual function, and then we'll do bladder. Okay.
What slide number?
I don't know. On mine it's 33.
Okay.
Might be the same for you. Yeah. All right. So I'm skipping ahead because we're going to skip some of the anatomy so we can talk about the autonomic functions, so that hopefully you can relate them with Mark's story on Wednesday. So the first is sexual function. So this is one of those areas where we don't have opposing actions. We have synergistic actions, actions that work together. I'm sure you guys have heard of point and shoot, right? Mm-hmm. And so what is point?
Parasympathetic.
It's parasympathetic, and it's an erection. Okay. Now, we want this to be coordinated, right? We don't want shoot without point. That won't work. Okay. Do we want point and never a shoot?
No.
No. We want this to be coordinated. Okay. And so basically, if our parasympathetic, this is not, a running from the lion. We can't figure this one out this way, right? So parasympathetic is where? Where in the nervous system is the parasympathetic? Craniosacral. And then the sympathetic? Thoracolumbar. So it's conceivable that you could have a sympathetic injury and not a parasympathetic injury. What would that lead for sexual function?
No shooting.
Point and no shooting. So just keep that in mind. Okay, that's all I'm going to leave you with that, right? So we'll hopefully talk about that and Some of you might think that's a really good thing. Not as much. And then the other thing, and Mark will talk about it, and I really encourage you, and I'll tell you this on Wednesday, to ask him. He will tell you anything. And this is a, what? This is just things you have to keep in mind. All right. Then the other big one is bladder and bowel. And this is so big. And you know, sometimes you have to step out of our little PT box for a minute and think about it. If you had the choice and you had an injury and you could either walk or you could be continent, which would you pick? Good. You said that. Most PTs walk, always want to walk. And you know, but the big thing is really continence. And so with the function of the bladder, all right, think about the line. We just talked a little bit about it, but we really have to coordinate sphincter control and bladder contraction. So just like any other muscle, they can become flaccid and they can become spastic. Either one is going to be what we call a neurogenic bladder. A neurogenic bladder is when we do not have neurologic control of that bladder. But we need to have coordinated control of the sphincter, because we need to do what, when we're urinating, we need to do what with the sphincter? Relax it, and what do we need to do with the bladder? Contract it. So we really have to have this synergistic contraction of the bladder with relaxation of the sphincter, or reverse if we're in the sympathetic mode. So basically, when we talk about neurogenic bladder, we're talking about some type of neurologic insult to the parasympathetic and sympathetic control of the sphincter and of the actual bladder muscle. So we need to, again, have thinking about it. So let's go to spastic bladder. So the spastic bladder, we've got normal or small volume, okay? Because it's spastic, it's contracting, it's not maintaining, it's not having a whole lot of volume because that muscle is tight, okay? Typically this happens with head injury of some sort, or brain damage, or high spinal cord damage, okay? And a lot of times with that, we're going to have sphincter relaxation, or they're not coordinated. This is what we see the most common, is detrusor sphincter dyssynergia, which means they're out of sequence. So with someone, well, yeah, let's go to that one. So this is our synergia. So we have urinary frequency and urgency. So they feel like they need to go. They feel the pressure, but they cannot relax that sphincter. So they cannot contract the bladder. So basically they can't completely void. So what would we do for this person? How will they handle this? Somebody with a spastic bladder, somebody whose sphincter is not, they cannot control that relaxation. Catheter, okay? So, but how do you think you're going to catheterize? And we're not going to get into the details of where you put it and all that, but is it going to be something you're just going to leave in there? Is this something you're going to do intermittently? You do have to, well, what do you think? Yeah, but do you think we want to leave a catheter in anyone? No. Why not? Infection. Okay, now this sphincter is closed most of the time. So why would we want to leave? These are the people that typically do intermittent cathing. They're going to straight cath themselves, or they're going to go in the restroom and they'll cath themselves. And so basically they're going to stimulate their sphincter to relax, manually or mechanically, okay, because it's spastic. Now what about a flaccid bladder? Or even a flaccid sphincter? Right, because it can drain any time. Now both can have accidents, because once the bladder gets to a certain volume, that's what's going to happen. But we can have a flaccid bladder as well. Here we have lots of volume because that bladder is flaccid, but if the sphincter is also flaccid, then we're not going to have, obviously, any control of leakage. So this is going to be somebody who's going to either have to be in some type of undergarment or some type of permanent or indwelling catheter. The point is, and you're not going to go through the whole bladder, but you're going to see people with problems where they feel like they need to go all the time but cannot relax to go, and you're going to see people that leak. And they're going to be treated differently. And what your job is to make sure they are on a bladder program and that they know how to handle it. Also bowel, and we're not going to get too much into bowel, but the same types of ideas is that the person needs to be on a regular bowel program and a regular bladder program. And what's the risk what's the risk of catheterization? Infection. And what's the risk of, one, it's from the catheter itself, but what's the other big risk with incontinence as far as infection that often kills them? UTIs. UTIs. So it's important for us to realize whether or not they have had UTIs. Whenever you know that somebody has bowel and bladder issues, especially if they have a neurogenic bladder, we want to know if they've had UTIs, how often they have UTIs, and if they're on a good program. So when that patient comes in with systemic infection types of symptoms, UTI is something that we need to consider. All right, and then the other thing I want to skip to, one more thing. Sorry I'm skipping around, but you'll appreciate it later, really. We're going to skip to slide number 57. And it's something called autonomic dysreflexia. Has everybody got this one? I think it's 57. All right, autonomic dysreflexia. Remember, we have those reflex loops and we have that visceral motor information that really needs to get up to those autonomic control centers, which we haven't talked about yet, to control blood pressure, heart rate, all of that stuff. But obviously with some type of spinal cord injury, that's not going to happen. So with our higher level spinal cord injuries, those above T6, basically our autonomic reflexes are not going to be able to be inhibited because we're not going to have that descending cortical control because the spinal cord has been damaged. So what happens essentially, and we'll look at it neuroanatomically in a minute, but essentially what happens is if we have some type of noxious stimulus below the level of the lesion, that information is not going to really be able to get up the spinal cord. So we're going to have those autonomic reflex loops happening, which cause all sorts of autonomic problems. It can be fatal. The big things that we see with autonomic dysreflexia as far as our symptoms is we see an increase in blood pressure and heart rate. We see them sweat. They have a pounding headache. That's very classic. They're flushed. They have chills and their bladder empties. So if we have a patient who is all of a sudden having increased heart rate, increased blood pressure, having a horrible headache, chills, starting to sweat, we need to consider that maybe this is autonomic dysreflexia. So that means that it was stimulated by some type of noxious stimulus below the level of the lesion. The most common are bladder issues and bowel issues, so that they haven't cathed, they haven't had a bowel program recently, they're constipated. It might be that something is pinching them. It could be a somatic issue, like their belt buckle, or they're sitting on their calf, or their leg is caught underneath their wheelchair and they're not feeling it. So it could be something somatic as well as visceral, but it's something below the lesion. So essentially what happens is the pain activates the sympathetic chain to cause this vasoconstriction, and we're not able to inhibit it because we don't have those pathways. So here it is, really on a step-by-step. So we've got a full bladder, that's our noxious stimulus in this case, which is really the most common, okay? That signal would normally go up the spinal cord you know, to signal the cortical control centers and so forth, but it's not gonna make it there. So instead what we're gonna have is we're gonna have a sympathetic response, okay? And that's gonna cause an increase that's saying something's going on, we need to increase our blood pressure and our heart rate. Okay, so that's step 3, okay? Goes up to the, basically through the cardiac channels going up through the vagus nerve. We're gonna have that information go to the brain, we can have that big headache, and then we're gonna have a cardiac response that way. So basically we're skipping this step. And this is looking at it another way. But basically we're having this vicious cycle of increased heart rate, increased blood pressure, and sympathetic response that's out of control. It's an uninhibited sympathetic response because we don't have that cortical inhibition, we don't have that cortical loop happening. And it happens again with any injury above T6. And so if you had a patient, let's say with an injury above T6, and all of a sudden their heart rate started going up, they told you they had a big headache, they were fever and chills, what would you do? What? You could call 911, but there's some things we can do first.
Well, you can look and see if there's anything obvious. There could be a cut that's infected, or it could be that their leg is twisted.
Right, so their leg might be twisted. What's the most common thing that's going on?
Bladder.
Bowel and bladder. So it's when was the last time you cathed? Or, you know, when was the last time you had your bowel program? Let's take care of that. And that's almost, and again, I want you to kind of talk about this with Mark, but it's almost always the issue is the bowel or the bladder. Now that's not to say that you haven't had the gate belt stuck in somebody, you know, or they broke a bone, didn't even know it. So that kind of stuff happens, but bowel and bladder. So first you want to loosen the clothing, check the calf, check their bowel program, and go through, and we'll talk about it next semester a little bit more, and then call 911. All right. So I know we jumped into a couple autonomic issues, but we'll get back into it. Any questions about that? So on Wednesday, again, we'll have a guest speaker talk about his injury, and I'll tell you again on Wednesday, but you know, one thing I'd strongly encourage you to do is to ask, because I remember definitely having this like little black box when I graduated of bowel and bladder program. Like, I can't talk about it, but I know it's something they do with nursing. And that was about it. And I really encourage you to figure out what it is. Not necessarily that you're going to do it, but you need to be aware of it. And you need to be aware of how important it is and how it's going to impact you. And one good thing is Mark will really talk about it. So let him tell you about it. Any other questions? All right. So actually, I know you guys are probably going to be mad at me, or some of you are going to be mad. I talked to the teachers, and I think it's going to be too crazy for the kindergartners to do 2 programs, just because I think it's going to be. So I think we're just going to do the one. But next year, I promise there will be more kindergartens. So just the 5 that actually signed up. If maybe we could meet just down in the second year classroom for 10 minutes.
Right now.
Right now?
Yes. But you can get your lunch, so if you want, or whatever, but it'll be 10 minutes, so.
The ones who wanted to do